If not, I'm going to just leave this to you or to read on your own. Okay. So let me know when I should move around, the thing. Let me know when you are finished reading. You are good? Still reading? Okay. I'm going to give you 1 more minute. Okay, now everyone finished reading? Give me a thumb up or nod your head to let me know. Okay. So we are going to move forward to this virtual simulation. Could you all see the video? Okay, great. So I'm gonna go ahead to play because there was no edit of this video, so we'll just start from here.
Hey, Michael. I'm Meredith. I'm your counselor assigned to Jane. Go ahead and get this chair. Now, due to the nature of the circumstances surrounding your admittance, I do have some questions for you before we start. Do either of you, before I begin, have any questions for me?
Is it okay if I stay in here?
It's okay with me if it's okay with Jane. Jane?
Yes.
Okay. So it sounds like you took some Percocet after you and Michael were fighting. Is that correct?
Yes, she was.
Michael, I appreciate you being involved, but I do want to hear from Jane in this circumstance. So Jane?
Yes, that's right. I was offered a teaching position at a prestigious riding school. And when I told Michael about it, he didn't want me to take the job. And he knows how much I want to be around horses again. So
I see. So you were upset. Did you wish you were dead or wish you would sleep and not wake up at all?
no, I was mostly angry at him, but I did not wish any of those things.
Okay. Have you ever had thoughts of actually killing yourself?
No, not since after my surgery, which was about 5 years ago.
Okay. And have you ever made plans about the intent to kill yourself?
No, not even when my accident happened. I'm not suicidal.
Okay. Then what made you take so much Percocet?
I've been back on my pills for a couple of months, and at first when I took my usual dose, it would make me feel better, but that didn't happen this time. So I took another one, And when that didn't work, I guess I just took another one and another one until I eventually became unconscious.
Yeah, so she was in our bedroom for about 30 minutes. And I went to check on her, and when she didn't answer immediately, I panicked and I went in, and when I found her, she was barely breathing.
Okay, so your body had gotten used to the amount you had taken, so you took more, but not because you wanted to kill yourself.
That's right. My pills usually help me when I'm feeling bad, and I just wanted something to calm me down. And they usually help with that.
Okay, well, would you mind if we talk about some safety strategies to help you cope better?
Yes, please.
Well, it looks like you have good support here.
I do, probably a little bit more than I deserve.
Okay, well, I'd like to start off with a quote by Helen Keller. Although the world is full of suffering, it is full also of the overcoming of it. What does that mean to you, Jane?
That means even though I'm going through something right now, I can overcome it and I can beat it, and I want to. It's been 5 years and I want to get past the person I've become.
Good. It sounds like you're motivated to work on yourself.
I am.
All right, well, let's get to work then. When we're healing from substance abuse, there are 3 stages: safety, mourning, and reconnection. So safety is where you are now. Your goal is to free yourself from substance abuse, gain more self-control, learn how to cope, not hurt yourself or others, and attain sustainability. Would you agree?
Absolutely. I don't want to put myself through this again, and I for sure don't want to put Michael through this again.
Great. So what does safety mean to you? I mean, normally I'd have you write it out, but I know you're hooked up to a bunch of stuff, so it might be difficult. So you can just say it.
Safety is a peace of mind where I can take whatever is bothering me or has hurt me and get past it without turning to drugs. Michael is safety, a place where I can feel and trust everything is going to be okay.
Good. It seems like you put a lot of fun into that.
I have. It's something I've wanted for as long as I can remember.
And how do you think you look for safety now?
I turn to my pills. They give me this false sense of safety and just mask my pain.
And do you think you're ready to learn some healthier safety tips?
Yes.
Okay, well, here we go. So let me hand you that. This is a list of safe coping skills that you can turn to when things get tough for you. So let's go over each one and see what your thoughts are. And would you read them aloud?
Yes. Okay. The first one is ask for help.
And this is something where you'd reach out to someone who you feel is safe. It sounds like Michael is that person for you. Is that right?
Yes, if he'll still have me.
Always.
Is there anyone else you'd like to add?
Not really. It's just me and Michael right now.
No problem. Our safe people list can always be added to. What's next?
And inspire yourself.
And this would look like carrying something positive or negative with you as a reminder. For example, a positive thing might be a quote or an inspirational poem or something of that nature. And something negative might be a photo of someone that you know who's passed away from overdose.
Okay. Could I use a picture of my horse as a positive? She's recovering well from our accident and living and enjoying her life.
That works for you. That works for me. What's next?
Leave a bad scene.
Good. And what do you think that means?
Leave when things get bad.
Exactly. Remove yourself from any situation that would lead you to using. Now I'd like to go through the remaining options, and I'd like you to pick 3 that you find helpful.
I think healing above all, saying what I really think, and creating positive addictions will be helpful.
Great. How so?
I think reminding myself that my goal is to no longer believe that I need the pills to feel better, and I want to move forward with a more trusting relationship with Michael. I've had a hard time not saying what I feel, and I just don't want to start a fight or anything like that. So if I try to say what I really think, maybe will help lessen the stress of all of that and stop the pushing down of it. And if I can put my energy into a positive addiction, it might replace the outlet that is for pills.
And what kind of positive addiction are you thinking?
Maybe strength training.
Oh,
After my accident, my leg has never been the same. And it's never completely healed, even though we have been on breaks. And I just didn't do any of the exercises my physical therapist suggested. So maybe I could work towards that.
well, that sounds good. Just be mindful of pushing yourself too far. Even positive addictions can sometimes be too much. So I encourage you to set healthy boundaries for yourself.
Okay. Maybe instead of my exercises, I could take up a hobby.
What do you have in mind?
I've always wanted to make handmade leather harnesses for my horses. So maybe that would be cool.
Yeah, that seems like something you could easily commit to. Let's start there.
All right.
All right, so moving forward, I'd like to schedule you for an outpatient program since you're going to be discharged tomorrow.
I need all the help I can get. So
That's what we're here for. So what questions do you have for me before I leave?
How often does she have to go to the outpatient thing?
Well, typically we start off with once a week, and then we can tailor it to her unique needs.
Is there anything else I can do to help?
Well, continue supporting her. It seems like you're Jane's main source of support, and that will be very helpful for her recovery.
Alrighty, I can do that.
thank you. And thank you. This has been a much needed check-in. I needed to get back on track.
All right, well, keep using your skills. It's a long road, but you're capable of getting there. And we will talk next week, okay?
All right. Thank you.
All right. Thank you both.
Okay, so that would be it. Just overall, I would like to hear from everyone. So how do you feel of the initial screening test in this video?
I like that she stopped Michael from speaking for her, just to kind of like make sure that we're just getting all the information from the client.
That is true. And also you notice that so when Michael tried to jump in and the counselor say, okay, so we would like to hear from the person, right?
Also the like interventions that the counselor used were like attainable and personal to the client. You know, riding horses is a big thing for her. And her little summary, it said that she had been doing it since she was either like a teen or a kid. I can't remember. So I don't know. I found it, I guess sometimes for me, I struggle with trying to like reinvent the wheel and it doesn't have to be a super drawn out, complicated thing.
That is true. Remember, so when Grace mentioned all those interventions, right? So I also like emphasized this with some of my supervisors. Okay, so it's similar to make a treatment plan. So you want to make it together with your clients because your clients knows themselves better than you, right? And what I'm saying, Grace mentioned is, so you want to make those interventions together with your client as specific as they can be and also as measurable as that can be. So yes, attainable, personal, specific, measurable, and of course, so it doesn't need to be a huge, complicated intervention. So yeah, what else?
Did I miss mine was cutting out. Sometimes if I don't like have the thing, it cuts out a little bit, but I heard the assessment for lethality. Was there a detailed assessment for withdrawal? Because she's talking about opiates and then it kind of sounded like that's what I meant by saying, I think it's ideal. Like, it sounds like a really great, like, case study, but I'm just wondering, like, she's been like using and relying on Percocet, which is a fairly strong opiate. Did I miss the assessment for the withdrawal?
No, I don't think it mentions anything about withdrawal now, because so in this case specifically, this client was facing the risk of overdose.
Right.
Yeah.
So I guess when I was thinking about like what we just learned was like assessing for the level of care need. And it
Mhm.
sounded like it jumped into just the plan of like safety and follow-up, and we missed the level of care and what we would recommend if it was
Right.
doable to her. That's the only thing I missed.
Yeah, absolutely. So that's actually something it has in my mind as well, like because when it jumps into all those next step, right? So what other like assessment you want to do to move forward to next step with this client? Because I mean, for this video is like only 9 minutes, right? So it couldn't be done with every step it needs. But if it's you, it's your client, right? Okay, starting with check-in, then what are you gonna do next?
I mean, I would have for sure started, TexCHIP, please, honey. I would have for sure assessed for the level of care, because before we do some of these coping skills and these strengths, I think finding out like, do I need to try to advocate for a resource if the client is wanting that, especially considering the substance being used. And I think it was easy to miss it because it is a prescription. It was, I think if like they would have said heroin, I think it would have been like really shocking. And so I think it was really easy to overlook it because it was Percocet, but that's still a very strong opiate that she just overdosed from. And I think that is where we look at, you know, setting her up for a comfortable, whether it's detox or, you know, then a follow-up treatment, or if it's just detox, if it's a MAP program or just outpatient. And I think that's where the next assessment should have gone, or what I would do with a client. I mean,
I appreciate
Yeah.
it, Liz.
Yeah, just to jump in, yeah, Elizabeth, thank you for that suggestion. That's really a very good idea. I think in this video, like, you know, of course, when someone overdoses, the next thing is to 911 and then they attend to emergency. So I feel like those process has been already done. And this is now, the client is kind of like knowing where she is, feeling okay, and it's almost time for her to be discharged. So they are now planning what is next when she's discharged. So I think that's so those things are very important. But in this place, it was kind of like it wasn't the stage where they are, and at the stage where they are is kind of like afterwards, her recovery. Yeah.
What other thoughts in your mind? Yeah, feel free to share.
It might be helpful to do like in the realm of assessment, something like a BDI, a depression inventory or something like that, because she says that she's not suicidal and like she didn't take the Percocets because of that, but she did almost overdose, and whether or not she realizes that, like, that's self-harm type behavior. And so she may not realize like the extent that, you know, it's affecting her. So maybe trying to get a better grasp on like, because the BDI goes from everything from like irritability to appetite changes and stuff. So it could be just add a little more comprehensive stuff.
Yeah, absolutely. So, and in terms of the stage of change, what do you think the client is, where she is now?
could you ask the question again?
So in terms of the stages of change, right? So majority of you are familiar with that model. So in this video, and from client herself, from her perception, right? And according to her statement, according to her own report, so where she is now in the stage of change.
Action?
action. Okay, so what is your justification?
Well, because she seems so willing to implement the having the safety person and trying to think of what they called it in the video. Like she was just so willing to implement the interventions, and I don't know, she seemed in a good mood. Like I don't know, I don't know. I could be wrong though.
What
I
others?
think yeah, looking at what she kind of manifests, it looks like she's in action, but also know that sometimes people can be, I'm not saying that she's being manipulative or something like that. And sometimes they might say, oh, I'm willing to take action, I can do this now, I'm ready to get this done, but actually deep down in their heart, they're just doing it so you can just, dismiss them so they can get out there. Yeah, so.
That's true. Honestly, I forget that that's a proponent sometimes, like especially being at Bayview. I hear that a lot, like, oh, they could be being manipulative, and something inside of me feels uncomfortable making that judgment about clients, even if it is true.
Right.
And
So
that's why I said we don't have to say that, yeah.
Mm-hmm. But it's important to recognize it could be a possibility.
it can be a possibility. Then how about everyone else? So what do you think where this client is about the stages of change?
I was gonna say, I think she's maybe in the contemplation because she hasn't really done anything yet. It's like maybe just the more planning phase. And then if she like actually starts like implementing the steps to start getting ready for that, then I would say that would put her in action, but it's just like talking about it right now. So that's why I was thinking contemplation. So
Yeah. Thank you for that. So actually in my mind, I also agree with the that word, you know what I'm talking about. So I just have difficulty pronouncing it anyway. So yeah, and the similar justification as Astra said. So she hasn't really put those action into, actual action, right? Those plan into action. So yeah, I would say it's also in the stage before action now. Okay. So next thing, I know so Liz touched on this a little bit. So I was wondering because so the counselor just jumping into to refer this client out and say, okay, so probably just put the client on the outpatient. So what do you think in terms of the severity of this client? You think what the best care she needs? Inpatient, outpatient, others? Or do you agree with the outpatient first?
I mean, it really depends on the client, I think, because what some clients may be able to do outpatient, others can't. I don't know that we have, just because it was a 9-minute video, I'm not sure we had all the information. Like, has she had prior attempts of, detox or outpatient? I know she had some recovery in there, but for me, I just found it to be something at least worth a conversation of, are we setting her up for success with outpatient prior to at least the assessment of, is she going to withdraw and detox? So, I mean, I don't know, like we go off like the least restrictive possible, at least in the psychiatric hospital. We always look at the least restrictive possible. So as long as she's safe and she has a safety plan and support system, I think outpatient can be a good place to start, and utilizing maybe that integrated approach where we're following up, with her, like she's following up with her doctors, anything like that, paying all that. Maybe we can start there, but at least having really good documentation that if in the future we may need to go a more restrictive or intensive
Mm,
program.
yeah.
Yeah.
I appreciate that logic behind this. So anyone else, then what do you think it would be the best step or the best care for this client at this moment?
I would be worried because she took a lot of the Percocet pills, and she said her intention wasn't to kill herself, but it could have been a deadly dose. So she might possibly, because is that an opioid?
Yes.
Yeah. So she could possibly be needing inpatient because it's an opioid and she's been ingesting so much.
Yeah. So, okay, everyone else, I would like to hear your insight on this.
I think we also need to take into consideration that inpatient is really expensive for certain individuals. So at the end of the day, can they afford it? And also, I think she already did an inpatient facility, and she's here. So maybe it didn't work for her. Maybe an inpatient or whatever inpatient program she was in wasn't the most successful for her. So maybe finding a different one, or yeah, at least trying an outpatient. You just got to look at all the possibilities and something that's cost effective for them, because we don't know what she's getting paid. We don't know what her insurance. So.
Right, that's a good thought. Yeah.
And I agree, just being curious, for some of you who work in drug and alcohol facility here in Corpus Christi, do they not have like a government or free insurance for individuals who have challenges with drug and alcohol?
I think like at Senecor there are like there's some type of program from what I remember, but not everybody qualifies, and it's only for like a limited number of days. I forgot what it's through.
Wow.
Maybe like Dish. I feel like it might be through Dish, like for certain clients. But I don't know what the qualifications are for that and stuff. But like a lot of them do have to use their insurance, and insurance will only pay for a few days. It's the same thing like whenever people need to go for inpatient mental health, you know. Like that's always a barrier. It's like, how much are they going to pay? How much is insurance going to pay? And then, you know, if you're private pay, or, you know, it's just
I know back in Pennsylvania, there's a lot of funding options for people who cannot afford. Inpatient is usually like 30 days and sometimes 28 days. But I don't know about here in Texas, so that's why I'm just being curious. Okay, what is that?
Yeah.
I'm sorry, I was eating, but I will say, I know that there's several indigent programs, and there's also what's called utilization management through LMHAs. They can help find funding for inpatient facilities for that, like if it's not qualified. So, I mean, they can find money, it's just putting that work in, that clinician to put that work in to actually find it. That's where the struggle comes in.
So I said it just for clarification, when you say, so they're going to find the money, right? So they're going to find the money once the money is there and they secure the money. So they're going to give it to the organization, the program, or actually just connect those money source to individuals.
Yeah, so basically they'll pay the center or whoever it is that's housing the patient. It'll go directly to them. And if the patient leaves AMA, then of course they get refunded whatever difference is.
Okay.
Yeah, but there are funds. It's just trying to locate them that is that obstacle. But there's a program here, well, in Texas for sure. In Corpus, it's called OSAR, and you can get it through 211. And I know they do a lot with Senecor, and they will try to locate a facility in the state of Texas to send you to if you are needing inpatient treatment for free at the cost of the state.
Okay, thank you for that resource. And also Liz mentioned OSAR as well. Yeah, I remember. So hold on, last year, yes, last year, who did this? I don't know. Someone from MHID so mentioned OSAR for some sort of treatment help for individuals. Yes. Okay. So just in general, what do you think people should, and also, so Betty, I want to go back to, stress what you said. Yes, so safety is actually a concern for the patients with, or at risk with, high dosage of anything they're using. So that's why we want to screen there for their safety issues and ask whether they have a plan to kill themselves, right? And also remember Grace said, so there's some incongruence there. So even though they're saying, okay, so I'm not going to kill myself, I'm not planning to kill myself. However, so the incongruence reflects at the part. So you're not going to kill yourself or planning to kill yourself, but you are using high dosage of your substance now. So how you're going to explain that, right? So as a counselor, when you catch that part, so how you're going to adjust this to your client?
Was that question at me or at the group?
As a group. Anyone who wants, to jump in, you're more than welcome to do so. No? Okay, so let's just reword this a little bit. How you're gonna use the confrontation here to address the incongruence?
I will say that you just have to confront it and say, you're denying, that your intention was to kill yourself, but you ingested X amount of pills. So can you help me understand that a little bit? Kind of thing.
Yeah, I do like that. What else? Thank you, Betty, for your contribution.
I mean, I think one thing you could have done just off the bat is had that, even if she had okayed Michael being there, had that private one-on-one time separate, just because I do think sometimes if you are confronting difficult things, you may clam up in front of family, loved ones, no matter how supportive they are. And if you really have a reason to believe there was an intention to end life, really, I do believe in addiction situations, it is very different, at least in my experience, than in normal counseling. Confrontation is almost necessary, and it's not really taken that offensively. There's a lot of that when you go into like an inpatient program or something like that, just because you have to have a little bit different type of approach. And also sometimes you gain the respect of people because addicts, and alcoholics, sometimes they just, how can I explain this? Sometimes it's a lot easier to have a very blunt conversation just because there is such a real world difficult understanding. And when you can meet them at that level, you kind of gain a level of respect with the issues anyways. But I think taking her away from Michael or asking him to step out of the room, if that's what you really are wanting to assess, would have been a really big part of it. Oh, my phone's gonna die. Been a big part of it, I think, for me. And then two, I agree. I think right there is where you just utilize your immediacy skills, you utilize your discrepancy skills, and you can do so in a really nice way. You know, almost like Araceli said, you know, on one hand, you're telling me this, but on the other hand, there's this. And there's this theory or this concept of any person utilizing substances to that degree almost has like a passive suicidality to them. Even if it's not intentional, there's this like passive aspect of it. And so maybe you can politely go that route and bring it in. But yeah, that's all I'd say.
I like that phrase, passive suicidality. Okay, so how many of you are familiar with motivational interviewing? Okay, I see a few hands up. So how you can approach clients with substance use disorders with the motivational interviewing?
Like they were talking about earlier, trying to point out incongruencies with their values and their behaviors to try and like spark some kind of motivation maybe, or like talking about what they want their lives to look like in the future. And again, pointing out incongruencies between their current behavior and like their desired outcomes.
Thank you for that, Hannah. What else?
And I would almost go like a solution focused sort of route. You know, what will life look like without this problem currently present? You know, what will the overall quality of life be like without this issue currently present?
So it's more like throw out kind of a miracle question there, right?
Yeah, sort of.
Okay. Yeah. Thank you for that, Danny. Anyone else? How many of you all have experience working with clients diagnosed with substance use disorder, any kind of substance? Okay. Yeah. So for those who haven't experienced, who haven't had a chance to, you know, have this kind of experience yet, then what barriers or challenges you think to work with clients with substance use disorder? Does that make sense? Yeah. For those who haven't had a chance to work with patients like that, so what kind of barriers and challenges you think you would encounter in your future career to work with them? Okay, I see Tristan provide a list of resources. So all of these are based in Texas, right? And are they like providing free treatment or treatment needs insurance?
It's just a variety of resources offered in Texas. Some of them have like sliding scales, some of them are free, some of them are government funded. Just a new list, I guess.
Thank you for sharing. Yeah. Okay, going back to the previous question I asked. So for whoever who hasn't raised your hand yet, I would like to hear your insight on this. It looks like everyone is tired and do not want to talk at this moment. So what we're going to do next is, so this is our last training for this semester. And if no one has anything else wanting to share, I will just make a few announcements here. So I sent you all a reminder of the telehealth certificate training, right? So we will need you to return the certificate by April 30. So we can just go ahead to process your payment, because towards the end of the semester, then, you know, people has a lot of work to just finish so they can have their break, and everything will be piled up. So if you could finish that as soon as possible and send it back to us, then also along with your very recent TVR log indicating you finished all those hours needed for the TexCHIP program, then also fill out the, we will send you, excuse me here. So we will send you the forms to fill out to process your payment. So, okay, that is it. What else did I miss? Anything?
Before you log off, I just have a couple of questions for you. So before you log off personally.
Oh, okay. Yeah.
Oh, for Union.
Or Ada.
Do you want both of us to stay, or you want one person?
It doesn't matter. Both
Okay.
is fine.
Just okay. Just last announcement for individuals who are continuing their last round of TexCHIP. These are the dates for the August, the summer training. So you all can have it in your calendar and know June 17th. That one will be combined with Dr. Hollenbach's on personality. And then June 8th, July 8th, and August 5th. And then I think August 26th, we'll have a symposium, but that one will be a visual one. You all are invited, but that's not compulsory and it's not part of your requirements, but just putting it out there. So these are the training we have for summer for those who are doing their internship and who are doing a TexCHIP in summer. So just put it on your calendar. It's also in the website, so you all know the information, yeah. Awesome.
Yeah, that is.
Congratulations to all those who are graduating from TexCHIP. We should have done some party for you all and say congrats. Probably we'll put it in next thing to do in the next summer. So when people graduate, we'll kind of give them a little package and say thank you for being part of TexCHIP and congratulations. Yeah, that's cool.
Okay, any other question before you all can just feel free to leave? Nope. Okay, so you all have a good weekend and thank you for being here on Saturday. Bye.
Okay. I just wanted to double check what you guys need from us currently is our updated TVR logs proving that we have the correct amount of hours, the telehealth training, signing up on that little sheet about what sites we'll be at. And then I think Ada sent out an email of a form we need to fill out by the end of this week, right?